Greetings from India. I, Dr. Amitabh Satsangi, Assistant Professor in Department of Cardiothoracic and Vascular Surgery, All India Institute of Medical Sciences, New Delhi, will be presenting a topic of palliative atrial switch procedure, and we will be discussing our results in our ongoing study. So, transposition of great arteries is the most common cyanotic cardiopathy with an incidence ranging between 0.2 to 0.4 per 1000 live births. So, most of these patients should be treated in the first month of life with an arterial switch operation, in which there's an anatomical correction that is given to these patients. But many patients in our country are not treated in the first few months of life, and they may progress with severe pulmonary vascular disease or a vascular obstructive disease. So, treatments of such patients include a palliative surgery to redirect the flow at the atrial level. So, the palliative atrial switch procedure is a surgical intervention used to treat certain congenital heart defects in children. Usually, it is a transposition of great arteries with the presence of an ventricular septal defect and a severe obstructive pulmonary arterial hypertension. The procedure involves switching the position of the pulmonary veins and the vena cava to redirect the oxygen blood flow to the lungs and oxygen-rich blood to the body. So, the transposition of great arteries with VSD and severe pulmonary artery hypertension. In transposition of great arteries, the defect that occurs is that from the right ventricle gives origin to the ascending aorta, and the left ventricle gives rise to pulmonary artery. When normally the left ventricle will give rise to the aorta and the right ventricle will give rise to pulmonary artery. Because of this, there is a cyanotic heart disease that is present. Then there is a presence of a ventricular septal defect in many cases, and because of the presence of ventricular septal defects, there is some mixing that is occurring. Plus, there is an increased pulmonary blood flow also is there. So, if the treatment to these patients is usually given in the first month of life or within 3 to 4 weeks, they can have a good prognosis, and an arterial switch operation can be performed, which is a gold standard for treatment of transposition of great arteries. But if the treatment is delayed and there's a late presentation, that is very common in our country, these patients with the presence of a ventricular septal defect and because of an increased flow in the pulmonary arteries usually develop pulmonary artery hypertension. And now, if an arterial switch operation is performed in such patients, there is a risk of mortality and increased complications and morbidity after a procedure of arterial switch operation. And it technically also it becomes difficult because of the disproportionate size of the pulmonary artery and the aorta. So, in such cases, the palliative atrial switch procedure is typically indicated, and the candidates for the procedure must be evaluated by a team of medical professionals to determine if there are good candidates for the surgery. So, the technique of palliative atrial switch is basically that the procedure can be performed using different surgical techniques, including the mustard procedure or the Senning procedure. Both the procedures involves in creating an atrial baffle to redirect the blood flow, and the choices of the technique depends on the factors such as the patient's age, size, and the overall health. Though a palliative atrial switch procedure usually leaves a ventricular septal defect open, which aims to improve the quality of life of the patient by decreasing the cyanosis and morbidity. If over a period of time the pulmonary artery hypertension decreases, then these patients can further be treated by intervention and the VSD can be closed by a device closure by interventional cardiology. The procedure improves the arterial saturation and reduces polycythemia and provides a better quality of life for patients with transposition of great arteries and ventricular septal defect. The procedure is considered in patients with late diagnosis when there is no current evidence of treatment for patients with pediatric age group with severe pulmonary artery hypertension. So, in literature also, it has been found that palliative stenting procedure improves the arterial oxygen saturation, it reduces the polycythemia, and provides a better quality of life to the patient with transposition of great arteries and VSD, or a TOSIC being anomaly in which there is a double outlet right ventricle with VSD and severe pulmonary artery hypertension. And when these patients were considered inoperable and had a poor prognosis if a arterial switch operation was performed. So our study was the aim was to report the midterm results of palliative surgical treatment in patients with complex congenital heart diseases with pulmonary artery hypertension due to an important intracardiac shunt which was not surgically treated within the period of considered safe. The aim at evaluating the early and the late clinical progression with palliative atrial switch procedure in this group of patients with contraindication to total surgical correction. So, a time period of this study was from 2014 to 2021. It was a single surgeon experience. Total atrial switches that were performed were 32, and total palliative atrial switch were performed in 7 patients. The retrospective study, based on the evaluation of medical records in the period of 2014 to 2021, only patients with a clear indication for palliative atrial switch procedure were included in the study, and we usually performed a Sennings procedure with a Schumacher and King's modification. So after a 1 year follow-up, there was a mean increase in the oxygen saturation from 62% to 92% and a mean decrease in hematocrit from 49.4% to 36.3%. The age range of our data was from 9 months to 20 years and the preoperative echocardiographic features were severe pulmonary artery hypertension and RV dysfunction. Cardiac catheterization had a pulmonary artery pressure range from 70 to 95 mmHg with the mean being 82 mmHg. The immediate post-operative evaluation, the hospital stay range was from 8 to 120 days. There was an improvement in systemic saturation. There was a betterment of functional class and activity in all patients. There were no early deaths. The significant morbidity requiring prolonged intensive care unit was noted in 4 patients, and out of those 4 patients, 1 patient had lower respiratory tract infection requiring tracheostomy and persistent pleural effusion was present. So on our 1 year follow-up data, it was there that the mean increase in arterial oxygen saturation was from 62% to 92%. Hematocrit decreased from 49 to 36%. All patients were in ROS or NYHA class 1 and 2, and there were no late deaths or significant pulmonary or systemic venous baffle obstruction or arrhythmias that was present. So, thus we concluded from our study also and the data that is available from other studies performed that there is in a palliative atrial switch procedure, there's an improved arterial oxygen saturation, there's an improved activity and functional class, there's reduced polycythemia and better quality of life in patients with TGA VSD with severe PAH and is there. So, usually, transposition of great arteries, if there's a VSD present, is there, so they can be treated with an arterial switch operation, which is a gold standard for treatment of transposition of great arteries. And usually, if a VSD is present, the ventricles are well prepared and they can be managed till after 2 to 3 months or 4 months after birth also. And if there's an intact ventricular septum, ideally they should be treated within 3 weeks of birth. But as the time progresses and there's the presence of a VSD, these patients usually develop a pulmonary artery hypertension and a severe pulmonary artery hypertension to a level when, if we close the ventricular septal defect and perform an arterial switch operation, then these patients have higher mortality and morbidity since it is technically also difficult since there's a disproportion between the aorta and the pulmonary arteries plus the patient after having an arterial switch operation with the VSD being closed, the ventricle, usually the left ventricle and the right ventricle will both become dysfunctional. Basically, the right ventricle will be dysfunctional more because of the severe pulmonary artery hypertension. So instead of going through an arterial switch operation with VSD closure, it is better to perform a palliative setting procedure or a palliative atrial switch, in which there's a physiological correction that has been given to the patient. There's an improvement in saturation. There's a decrease in the polycythemia and overall functioning of the patient, and a VSD is left open so that the pulmonary artery hypertension that is there will not cause the ventricular dysfunction. And over a period of time, if the pulmonary uh, vascular resistance and the pulmonary artery hypertension improves with medication, then this VSD can be later closed in a later stage, or it can be closed using a interventional cardiology local procedure like a device closure, or later on these patients can be converted for an uh, takedown of the atrial switch and performing of an arterial switch later in the period if the physiology permits. Thank you.